back to another episode of the Fill Me In podcast, where we dive deeper into the world of aesthetics. This is Injector John.
And aesthetic nurse Nicole.
And we have a very, very special guest today, a board-certified OBGYN, Dr. Simons. Thank you so much for joining us today.
Oh, thanks for having me, John. Thanks for Nicole.
And yes. He has probably the coolest Instagram name or handle I've ever heard in my life. You can follow him at Punk Rock OBGYN, which is incredible.
Love it.
And for those of you that are watching on YouTube right now, he totally looks the part. So, but Dr. Simons, we wanted to have you on because we have a huge topic is pregnancy safe treatments in the world of aesthetics. And there's a lot of literature out there. You know, people want to know, can I get Botox when I'm pregnant? You know, or I'm breastfeeding. Is it really going to harm the fetus? Can I continue using retinols while I'm pregnant? What pregnancy safe skincare is there? And obviously, Nicole and I are well versed in a lot of those pregnancy safe medical grade skincare treatments, but we wanted you on here, and Nicole is pregnant as well. So
yes.
What
Excellent. Congratulations.
Yes, thank you. Yeah, so I've just been getting so many questions, so many DMs about what's safe and what can I be doing, what shouldn't I be doing. So we thought it'd be a great episode. We kind of wanted to start out with the changes that pregnancy causes. Definitely we see increased pigmentation, stretch marks, sensitivity, acne. But if you could kind of dive into that a little bit, melasma. Yes.
Yeah.
Yep.
So sure. So pregnancy hormones, when we think of traditionally, you have a lot of changes in hormones overall in pregnancy. The first really is your beta HCG, which is what's positive when you take a pregnancy test. So this beta HCG sends a surge of progestins as well as estrogens in the female body. And then subsequently, you have a gradual rise of progestin and estrogen over the course of pregnancy until they abruptly are taken away after you deliver. And so what that leads to is actually a lot of changes when it comes to hair, when it comes to skin, when it comes to your nails, and, obviously many other systems that we're probably not going to touch on today, but in regards to you guys, can play havoc on a patient's appearance or how they feel. And so, estrogen and progestin are your main culprits and probably the ones we focus on today. But you see a lot of changes when it comes to this pregnancy hormones. And and that can be evident even when patients are just taking hormones or having changes in their hormones. They might have skin changes and hair and nail changes as well.
Right. Now, does it matter if, whether we're having a boy or a girl? Is there, does it depend on, because you hear so many different stories from women saying, oh my God, I had two girls, my melasma was so bad with them. I had a boy, I had none. Or, or is it just kind of like your body? And
they say the girls steal your beauty.
Yes.
Boys have more heartburn. I hear that one a lot in the office. I
will say I've been having heartburn. So
that's a progestin mediated one. Progestin is kind of, you can point your finger at all of that because it dilates your smooth muscles, slows down your GI tract. So, when it comes to things like heartburn, constipation, all of those, poor digestive issues.
Fun things,
that's because of that progestin. But I don't think that there's many differences in estrogen and progestin based on the sex of baby. So, I think that we have a lot of anecdotal things. Every pregnancy is different, right? So people like to have answers for those questions, but that's not going to matter. So. Do you know what you're having yet?
It's a boy.
All right. Well, Chris is a great name for a boy or a girl. I'm just throwing that out there.
I'll keep it in mind. Add it to the list, my ever-growing list. Oh, my God. I think our major thing that we get all the time is the melasma talk.
Sure.
And when I was kind of diving into this, I also saw, I'm going to probably butcher the name, but colasma. So the differences, and not everyone gets melasma, right?
I think they're the same thing, aren't they?
Yeah,
it's just a diagnostic term. Melasma?
Right. Yeah. So it's really just so there's different places that you can get melasma, and melasma, is kind of just another way to talk about the same thing. But what it is really it's a kind of a characteristic hyperpigmentation, and that can be very apparent, like in the cheeks and upper lips, nose. And it's actually very, very common. You'll find that about 75% of pregnant women will report some sort of like hyperpigmentation and changes. And again, that is estrogen and progestin mediated. And there are risk factors, right? If you have a family history of it, if you have a lot of exposure to sunlight, and then characteristically, if you are closer to the equator traditionally, that you're going to have greater amount of melasma clinically. But the good news on this one is for a lot of people, it will clinically regress. So as those hormones go back down, you will see an improvement. Some people can have like a little bit of change that stays with them kind of forever. And then, the more pregnancies that you have, the more up and down your hormones go, these things can, stay and then bother more people over time. But we usually say that the majority of people, it will regress within a year. I know a year is a lot of time. Maybe we're hoping that they don't come back and ask about it again. Or they've moved on, to you guys where, they're moving on to getting peels and treatments to deal with it at that point.
Now, also too, I know, Nicole, you're suffering a little bit from perinasal and perioral dermatitis, which I know can, I think, be exacerbated during pregnancy and like the hormonal changes. So is that something common that can happen too as well, Dr. Simons?
Oh, yeah. So everything. So mucous membranes in general kind of go by the same concept as the rest of the body. So we talk about those physiologic changes that are mediated by progestin. A lot of those is because you're taking on extra fluid. And that fluid is going into those extra spaces inside your cells and inside your skin and all of these extra tissues. And so your mucous membranes are no different. Classically, one of the things we talk about are pregnant patients are difficult to intubate. Why? Because their throats, everything gets bigger and full of fluid, more edematous. But then also that plays part in too when we think of like lower extremity swelling, when we think of, your face and neck, your hands, all of these spaces are actually taking on fluid physiologically over the course of 9 months. And this can be a physiologic adaptation of us over time, just actually preparing for hemorrhage, right? If you store a lot of fluid, then as you have that, rapid remodeling of your heart during delivery, you might have a rapid loss of fluid or rapid loss of blood. And so you have that ability to pump that extra fluid that you've been storing back in circulation to help, physiologically survive. Now we have plenty of IV fluids. We got plenty of blood. We don't need it as much, but our bodies don't know that. We still think, oftentimes that we're, out under a tree or, in a field or something, so, and
your
that's
body's
kind of
still prepping, right? Yeah.
Exactly.
Yeah. I noticed that with my, my sinuses. They're definitely inflamed. And when I go to take like a deep breath through my nose, it's not the same.
Yeah.
Not the same like it used to be. But yeah, the perioral dermatitis has been so frustrating. I just started metronidazole cream.
Okay.
But only 3 days in. But yeah, it's hard to treat. I was moisturizing like crazy. I think the weather doesn't help.
No.
Yeah.
Yeah. We go from 40 degrees and then it's -9 with wind chill today.
Oh my God.
That doesn't help.
Yeah. But
Jonathan's got a full on, sweater and everything on already.
Oh my God. My office is like
Inside,
2 degrees in here.
I saw fire before.
You'd think you were in your front yard, John.
Well, and I have a heater underneath my seat right now too. It's just cold in this room. God. I don't know what's going on. My dermatitis is going to be flared up very shortly
seriously, especially with that heater.
Oh yeah.
Hey guys, just popping in to remind you to like, subscribe, and hit the bell for notifications. Also, don't forget to follow us on Instagram, Injector John and Aesthetic Nurse Nicole. Thank you so much for watching. And if you have any questions, leave it in the comment section.
But on top of like sensitivities, like dermatitis, you see a lot of acne sometimes too, right?
Right.
Oh yeah, very common. So I'll actually see like 50-50 with acne. So, because there are a lot of women out there whose acne might be hormonally mediated to begin with, because they might have PCOS or they might have excess estrogens, excess androgens. And so a lot of times you'll see women who have, especially in the first and second trimester, their acne will get a lot worse. And then sometimes in the third trimester, it can get worse. So it's really person to person dependent. But I kind of see it go either way. And then also you have like your sweat glands, they will increase and they'll be more just like you'll get hyperplasia, an increased amount of your eccrine and apocrine glands, and then the sebaceous glands as well. They can go up and cause increases in acne, and so any hormonal changes, right? You know,
so
we talk about
more oil, clogged pores, congestion.
Yes. 100%. And too, you know, a lot of people change their routine. And you also, we ramp down immune system. So your barrier immune system, so skin, hair, those things actually, you know, get turned up from all of this excess fluid. But your learned immune system, things like immunity to viruses and such, gets turned down. So when you're talking about, you know, problems with your mucous membranes, et cetera, that can play a part of it as well.
Yeah. And it's tough because, like you said, you got to change your routine. So you got to take out that retinol if you were using it. And, right. Yeah.
Yes. Retinol is not, that's one that we know is not good in pregnancy. We don't do a lot of studies on pregnant women. We don't have a lot of people signing up.
Right.
So a lot of these studies, you know, are retrospective. They're after things have come out and the possible repercussions of them. But so retinol is one that's fairly common, you know, it's common out there. And we typically recommend having a reliable form of birth control if you're on retinol products, especially because, you know, many of the people that are on it are young women or young people.
Right. Especially any form of oral retinol too, right? Like any kind of Accutane. I've done Accutane in the past many years ago. But anything like that, you have to be so careful with.
Yeah.
The pregnancy glow, that's related to an increase in oil too, right?
So, you know, my thoughts on pregnancy glow. So you have high estrogen, right? You've got hyperpigmentation of the skin. You've got increase, you know, fluid volume and hydration. You know, you're going to look like you're glowing. Most people are walking around, you know, their estrogen's low. They're dehydrated. They're not feeling good, you know, and then you add it, you know, pregnancy. Oftentimes people can be very happy about pregnancy, but it's definitely, you know, I think you guys probably, a lot of the products that you guys use, a lot of the treatments are aimed at hydrating skin, right? And so physiologically, I mean, you're giving patients extra hormones, and then you're making sure they're well hydrated. And I think, you know, half the time when I see patients in my office, I'm asking them, I'm like, you know, what color is your pee? You know, is it clear? These are things we talk about, you know, and I'm like, because I can tell, like, are you hydrating enough? And, you know, and that's one of the big things.
Yeah. So, it's so funny because normally I'll get up like 5 times a night to pee. And last night I slept through the night and I'm like, I did not drink enough water yesterday.
100%. That's an indicator.
Oh boy. Well, it's so funny we're talking about retinol because there's she's an esthetician, but she's an influencer on social media, and she talked about, Nicole, like how she's used retinol during pregnancy.
Really?
She did her own research and things like that. Like, I won't name her name, it's fine, but she publicly talks about it, how she did it through her pregnancy, and says that, you know, she thinks it's safe and it's fine. But
nice.
I don't know.
Yeah. You could, I mean, so, you know, like, babies are resilient, right? Like, we as a species have been propagating from the beginning of time. We want to survive, you know, and our bodies are constantly trying to self-regulate, constantly trying to fix things, you know, but if we do enough to mess it up, we can mess it up. Right. And so, you know, retinol has been, you know, associated with like heart problems, with cleft palate, with CNS problems, deafness, blindness, hydrocephalus. So there are a lot of things. And again, everything is probably, you know,
those are very severe. But I guess my question is, it's like, what percentage of the topical retinol is actually making it, you know what I mean? And you know what I'm saying?
Right.
Well, like, everything is dose dependent, right? You know, so a lot of these studies, like, for instance, how many people are out there and are on a product like this and then find out they're pregnant and then discontinue it. And so, you know, the overall number of birth defects associated with this is going to be fairly low, but we do know that it puts you in that higher risk bracket, you know, for developing those things. And so, you know, we would say stay away from them because there is a chance of those things happening. And again, it's probably going to be dose dependent, you know, if you're someone using it every day, and then for the entirety of organogenesis, which we're talking about 5 to 8 weeks, you know, pregnancy or most of the organs are developed, you're probably going to see, you know, a higher percentage of birth defects or problems with that. So, you know, I know this is for a lot of entertainment purposes, but stay away from retinol if you're thinking
if you're pregnant.
Pregnant, you know, there's no safe. Like a lot of things, there's no safe amount. Less is better.
Right.
Probably
and
more worse.
Obviously, you know, Botox is an absolute no if you're pregnant. Now, when you're breastfeeding, you know, we have so many patients that after they pop that baby out, they're like, I need my Botox. Like, you know, I don't care if I'm breastfeeding. I'll just pump and dump for a couple days. I have so much milk stored. Like, what are your thoughts on that? Because I know there's been like recent literature that just came out too.
Yeah, there was a recent study. Yeah.
So, you know, the thing about Botox is, so there's a lot. First off, let's talk about the physiology of Botox, right? You know, so first off, Botox is something that you're probably not using every day. You know, in your, you know, in your field, you're using it at probably one injection time, you know, and then maybe, you know, you're not something that you're using on a weekly basis, you know, it's something that you're doing maybe quarterly, let's say. And so again, there's been a couple anecdotal studies and a couple, you know, just retrospective looking back on people who've gotten pregnant, especially when it's Botox for migraines, because there's a lot of data on that. And then there haven't been any adverse outcomes based on those retrospective studies. And so now with breastfeeding, there hasn't been a tremendous amount of literature, right? We have, I did see one study that was on PubMed that you guys had shared with me before, you know, where it said that there was, I think it was 4 lactating women with 16 samples, and they had 8 had a detectable amount of Botox in breast milk. It was well below, you know, what would affect the fetus. So, I mean, based on that, we would probably say, yes, is it detectable in breast milk? To some extent, probably. Is it going to be enough that's going to affect the infant? Probably not. So, but what would the safest thing be? To not use it because it would be detectable in breast milk, to wait till you're done breastfeeding. You know, and then it would be probably a good study would be, how long does it stay detectable in breast milk? You know, that would be the next thing, so that we can get, because there's a lot of medications, whether you're getting contrast or something, you know, if we could safely have a, you know, a well-studied time frame that says it's detectable in breast milk for 24 hours, that gives us a great recommendation for people to say, you know, what's safe and what's evidence-based. You know, I think right now, especially with the litigious nature of OBGYN, of, you know, giving birth, we don't want to do anything that's going to jeopardize baby. Right. You know, it's everything. We want to look back and we say that we didn't do anything to harm anybody. But this is something that is very common. And so we should be getting a much larger data set over the next years as Botox is more readily available, as more people get pregnant or are pregnant and getting Botox and didn't realize it, you know, it didn't realize they were pregnant before they were going in. We should get some more data on that. And we should also, you know, have more studies available that say, how is this transmitted in breast milk? How long is it present in breast milk, and what levels? Because, you know, like every other medication out there, we do a fairly good job of investigating these things. And I think it's probably you know, well worth the time and effort to find that out, because it's becoming more and more common, right? You know, so I think that would be great. My disclaimer would be that, you know, as of now, we don't have the information yet. So the answer is always going to be, you know, the safest thing would be to avoid, the safest thing would be to abstain. But that doesn't mean that won't change once we get more data. And I hope that we do, because, you know, the accumulation of data in these scenarios, all of these asking the questions about these things is going to give us better answers over time.
Right. Yeah. And I was so excited to see this study. And then I saw it was only 4 participants. I'm like, oh, it's only 4 people.
I know. You know, we have so many people lactating out there, you know, I feel like we could fund this study.
Oh, we definitely could.
Give me some samples, everyone. Give us, send us some emails. That'll be my next study. But yeah, I read that and I was like, ooh, I don't know, as a expecting mother myself, if I would be comfortable knowing that there is trace amounts, you know, being in the milk. So it's a tough decision.
Yeah. The other thing with that was that they monitored it on lethal dose. So
right.
lethal dose of infant is a lot of Botox. So
right.
I hope they're not trying to titrate that one.
Oh my God. And what, isn't it like 3,500 units for adults, I think?
For adults, yeah. So it's probably, I can only imagine what it is for infants, but
probably half that.
Yeah. Yeah. But I think another question too, that we get a lot of the time along with, breastfeeding and Botox is if I'm doing like IVF or if I'm trying to get pregnant. I always say if you're trying to get pregnant, I think honestly, it's fine. You're not currently pregnant, but IVF treatments, what is your thoughts on that?
So it depends. So IVF gets really complicated because what happens is you have a lot of different spinning variables, right? Mm-hmm. And so it depends really where in that process you are. If you're, in the process of egg retrieval and harvesting, it's probably best to stay away from it at that point. Mm-hmm. But again, and these are short time periods. If you're actively taking injectable medications to stimulate egg retrieval, I would probably recommend trying to eliminate as many variables as possible. Mm-hmm. But again, this is a very short time in the IVF process. If they've already, taken your eggs, if they're, getting ready for implantation, again, it would be talking to that reproductive endocrinologist, getting their thoughts. I mean, I don't see a lot of contraindications to that if they, but again, there's so many different parts and moving parts, and a lot of these, it would really depend on where it is and when it is.
Yeah. Yeah. And like you said, like there's already so many variables. Why add another one? Yeah. I always say if you're on IVF, when people ask me, I'm like, it's better to just hold off, in my opinion.
Yeah. So like I said, the safest thing is to stay away. We're always, whenever a patient is having infertility or a couple is having infertility, we're trying to eliminate as many variables as possible. And a lot of medicine is just that, the process of elimination. Right. Do we have good eggs? Do we have good sperm? Do we have a good cavity? Do we have any medications or, stressors and all of these things? And we also need a little luck, right? Mm-hmm. So we're trying to eliminate variables and not try to add them.
Yeah. Yeah. And I'm sure you get that all the time, John, too. Like people asking, well, we're trying to get pregnant, but we're not pregnant yet, but they're not doing any kind of, IVF or anything like that. And then I'm like, okay, no, you're good.
It's all the time, all the time. And my big thing is like you said, like if you don't know that you're pregnant, it's okay. And I can't tell you how many women are actually testing. I mean, they're testing like every other day, if not once a week, if they're pregnant, if they're actively trying. So usually like I'll have someone saying, oh, I took a pregnancy test this morning. I was negative. You had an opening. I'm in. And I'm like,
yep.
Yeah.
Oh yeah. I want to go back to the hair changes because I feel like this is a big topic too. Sure. During pregnancy, your hair gets thicker. Mm-hmm. And then after we start to lose a little bit of hair.
Yeah. So, one of the biggest things, with hair growth in pregnancy, you have, like I said earlier, high estrogens. And when you have very high estrogens, it actually floods the estrogen pathway. And so some of those estrogens actually get converted to androgens. And this is what we see in women with PCOS, right? PCOS is not because they have high androgens overall, it's because their estrogen is so high. And so like I tell many patients, I say when there's too much traffic on the bridge, people start to take the tunnel. And so when they do, you get that secondary hair growth. So hair on your lip, hair on your chest. You can also have hair on your face, legs, back, like anywhere that might be, when you think traditionally of testosterone. And so, and for many pregnant women, they'll get that hair growth like on their belly and in new places. The good news is a lot of those, as those estrogens go down, a lot of those hairs go away. For some women, it might stay and you might have like terminal hairs that kind of, take take root. But a lot of times, we'll say, like laser treatments, etc., for those after pregnancy usually. But then postpartum, what happens is that we take all that estrogen away. And so then you have this hypoestrogenic state. And that also could be exacerbated by prolactin. So prolactin, which is generally the hormone that helps with lactation and creating breast milk, will actually override ovulation, override estrogen and progestin. And for some women, that can make them feel like they're menopausal. It can make them feel like they have vaginal dryness. It can have their hair can get really thin in the front. That pregnancy glow, it kind of, we take it away. And that is another biologic function of, I don't have enough resources to produce another child at this point. But, in doing so, for many women, it can make them not feel very great. And so you can have that, like I said, frontal hair loss and thinning, associated with that, just a lower estrogen.
And that's more of just a waiting game too, kind of giving your hormones time to level out.
Yeah, for a lot of women, and that can be, like I said, exacerbated by long-term breastfeeding. But a lot of times it'll normalize after, 3 to 6 months. Not a lot of women don't want to hear, we're hoping your hair gets better in 3 to 6 months, but it usually does. And it usually goes back to where it was.
I love seeing it. Like I'll be like doing their frontalis injections and all of a sudden I'm like, oh, look at these little baby hairs just coming in.
Just sticking right up.
And they're like, thank God this needs to grow quicker,
Yeah.
I'll tell them there's hope.
Yeah. I was thinking after the fact, PRP injections might be beneficial for, kind of if you're trying to supplement the area, give it as much as you can.
Dr. Simons, I wanted to bring up too the GLP-1s.
Okay.
Yeah. So there's a lot of patients obviously that are on them for weight loss, or for PCOS and things like that. And it's helping them tremendously, but they're also finding that they're getting pregnant easier on them.
Oh, this is a huge thing.
Yeah. Yeah. Do you want to add anything about that?
Yeah.
There's so much. Where do we start?
All right. So I do prescribe GLP-1s. I do use them off label for PCOS.
Okay.
I have many women who come in with abnormal periods, and they're on that spectrum for PCOS. And we talk about the main goal for them is in treating their abnormal periods or their symptoms is often weight loss. And these are women who have been not lack of trying, they're eating right, they're exercising. And a lot of times they just need that little bit of nudge to get over, and then start that metabolic process where they start losing weight. And I'm really seeing a lot of not pregnant women. A lot of women have a lot of success in regulating their periods with weight loss, as well as their symptoms of PCOS, including abnormal bleeding, including increased androgens and hair and hirsutism. Now they're also getting pregnant because they become super fertile. So that reduction in, let me start back, that extra estrogen and excess androgens acts as a birth control. And so it is preventing ovulation for many of them. And as soon as we get rid of some of that weight, as soon as we get rid of, it goes that down. Metabolic resistance, they're super ovulation. Yep. They're fertile myrtles all of a sudden.
No, they really are.
It's wild.
My husband's a board certified family medicine doctor, and he does the GLP-1s at my office. I know, Nicole, you have Meg at your office who does that as well. And there's obviously so many off-label uses for GLP-1s. And my husband's got a few patients that have PCOS, and their periods are becoming more regular, and they're losing weight, they're feeling better, their hirsutism's improving, and they're just overall so much happier.
Yeah, it's great. We're trying to use them, or I'm trying to use them, more often and create more accessibility to them. There's
it's funny.
A lot of go.
There's this doctor. I don't know if you know him, Dr. Kiltz. Do you know Dr. Kiltz?
Nope.
He owns CNY Fertility, which is in Syracuse. I think he's got a New York clinic. I think he's got a bunch of clinics, and he has this book that's called Plants Will Kill You. He's very much like a keto, like carnivore diet. Like he believes in like meat, cheese, butter. He wants you to put a half a stick of butter in your coffee in the morning, you know? So, I mean, yeah, you'll end up on the cardiac cath table, but he's basically saying by doing a more keto diet, it will decrease inflammation and then help hopefully get you pregnant more. And he's a very big, firm believer of that. But I mean, with the GLP-1s and right, like there's a more peripheral uptake of glucose, right, with that. So it's helping to regulate, giving people more glycemic control, and all that. So I think it's helping with decreasing inflammation systemically too.
Yeah, it's really, you know, I've had so many patients that have started their journey coming in saying, you know, I know I'm overweight. My periods are irregular and I want to get pregnant. And, you know, I think in the past it was like, well, you know, we're going to try to do one thing at a time. You know, I'm going to look at this and I'm going to prescribe you a birth control. I'm going to refer you to a bariatric surgeon. And, you know, then we're going to get you on, you know, ovulation induction with Clomid or something, which increases your chances of multiple. Right. So a lot of these things. And now it's like looking at it from a completely different light. Yes, you can do all of those things, but it's like, no, let's get you, you know, on a path where we're kind of going to treat all of these things all at once. And, you know, and we're having such success with it that it's really, I mean, for me, it's been really awesome and very, very fulfilling too.
Yeah, because I feel like in the past for PCOS too, it's been like, okay, here's a birth control, try this one or try the next one. Right. So that's kind of like you're treating that, but getting so many other benefits as well.
Absolutely. And you know, you see all different, you know, again, PCOS is a spectrum. And so you see lots of different patients along that spectrum somewhere. And not all of them, you know, are going to be, you know, not all of them are going to have a super high BMI. It might just be slightly elevated, but that might just be enough biochemically, you know, or hormonally, you know, to prevent them from ovulating correctly. And so it might be just, you know, a little bit. It might just be a little bit off, and maybe they just need a little bit of a reduction of BMI. And so, you know, it's been working really well.
It's amazing. With weight loss, I feel like too, a big question I get all the time is the stretch marks. And is there like a true way to prevent the stretch marks? Or are they just hereditary?
So stretch marks, for those of you, you know, guys who don't know about them. So like they're very common, you know, they've happened usually around 6 to 7 months. Generally, you know, it'll be around the abdomen, but you can also get them in the upper legs. You can get them in the breasts as well. Not a good way to get rid of them once they're there, but there is some prevention for them. Okay. And so when we talk about prevention, you know, the biggest risk factors are going to be like if you have a history of a lot of abdominal or breast surgeries before, if you have a high BMI, or if you have using chronic topical steroids or corticosteroids, you know, that like thinner skin because it's exacerbated by rapid weight gain. And then also if you have a larger pregnancy, so multiples, if you have polyhydramnios, which is an abundance of fluid inside the amniotic sac. And so you can do risk reduction, you know, to help prevent those things, right? So we have a gradual, healthy weight gain in pregnancy. We don't want, you know, I get pregnant and then I gain 40 pounds, right? Because your skin only has so much elasticity, right? You know, and so if you have a rapid gaining of weight, if you have, you know, a lot of pressure on that skin, it's going to cause, you know, some stretch marks. So I tell patients, I say, you know, make sure you're watching what you're eating, make sure you're exercising, make sure that, you know, if you're prone to diabetes, that you're eating the right things at the right time, you know, and that we do your glucose tolerance test, because also being non-diabetic, you know, even though many patients can't help it in pregnancy, but better controlling that sugars is going to lower their risk of polyhydramnios. And so less tension on that skin, less tension, you know, overall. And so there are lots of studies of this, you know, different creams, cocoa butter. I hear that a lot, you know, lotions and things that can help prevent that skin
oil. Yep.
Sure. And the bottom line is treat your skin well, right? You make sure it's not dry, make sure that you're using lotions, that you're using good, safe products and keeping good hydration to prepare your skin. Cause you're going to have some stretch, you're going to get big, you're going to have a baby in there. And so, don't beat yourself up.
Right. It's going to happen.
It's going to happen, and so you just got to try to be as healthy as possible. And some patients will avoid it. And I've seen it, again, both ways. I've seen patients that have two babies in there and they got 12 pounds of baby in there and polyhydramnios and they don't get any stretch marks.
Right.
And then I've seen patients with a tiny baby that get stretch marks. So, sometimes you get dealt a hand genetically and you gotta play that hand too.
Right.
So some people,
I think that's what it is too. I think it's their ethnic background too.
Yeah.
And,
you get so I tell patients all the time, you get some patients get dealt a really good hand and you can eat whatever you want all the time and that your heart looks great and you're ripped and in other patients we gotta like work at it and eat right and take medicine. It's the worst. It's not fair.
Life's not fair, right?
Yeah.
John, too, after the fact, any stretch marks, we could always do microneedling.
We could.
As an option. Yeah. That's something that might be beneficial out there.
Yep. And for those of you that don't know what microneedling is, it's just basically these little microneedles that we run over your skin and cause little micro injuries that stimulate collagen and elastin. So basically it helps to smooth those, the scarring. We use it a lot for acne scarring too, but we can use it for stretch marks as well. And it probably will require multiple treatments, over time to improve.
I think now would be a good time to stem into like what's safe and not safe when it comes to treatments that we perform.
Okay.
I definitely know that so many people want to do everything while they're pregnant and you just, you can't. We already touched base on Botox. Sure. Fillers are in the same ballpark. Right. Yep. Again, it's just
which we get so many people that are like, it's hyaluronic acid gel. How is this going to affect my baby? I'm like, because there's not enough studies.
Exactly.
Yeah. It's I still tell people all the time. It's like I don't know. Yeah, it might do something, might not. There's lots of things. So, the big thing that people look back on is DES, when was that? The 1940s, 1970s, and so the less in pregnancy, probably the better. But, in the biophysics of Botox and hyaluronic and fillers and things like that, it doesn't, it's not things that are going systemically. So I think over time we'll probably get a much larger, sample size and we can start, making some jumps to real conclusions eventually.
For those that don't know what DES is, isn't that it was that injection that was given to mothers to prevent a miscarriage?
Yeah, it was, what is it? Diethylstilbestrol? Yeah. Yep. So that was like 1940s to 1970s. It was a medication to prevent miscarriage and it was an estrogen based product, synthetic estrogen, and did lead to increased cancers, not only in the generation of those moms, but in their daughters as well, which we're actually still seeing because you're born with the eggs that, those eggs. So it actually affected multiple generations. And so,
it's amazing. Yeah. It's crazy. The body's crazy.
So there's actually a foundation called Marine's Hope in Syracuse, New York. And it was founded based upon that. It's her sister who now runs the foundation, but her sister was, she passed away from one of those deadly cancers. Her mother had gotten that shot. Yeah. And then obviously gave birth to her, the whole thing. Yeah. And it passed on to her. So crazy. On that note,
that's what a downer. But the stuff that I brought it up. I'm the worst. But the thing.
People are going to be like, "What are DES?" And I'm like, "Well, actually, I know about it because of this foundation."
That's a med school question. They definitely they asked that one in an exam somewhere.
Nerd alert! Oh my god!
But so your Botox, your fillers, but then you also have to stop your laser treatments, your laser hair removal.
Oh, you do? Yes.
Darn. And I think that there's two reasons for that, right? One would be the skin healing. So you don't want to increase anything that could potentially increase your pigment, especially with that risk of melasma and things like that, right?
Yeah. And you can have any skin reacts very strangely in pregnancy. So, I mentioned before that your skin, like it increases your physiologic resistance with your barriers for your immune system. So the body, a pregnant woman's body doesn't want to recognize the fetus as an invader, a foreign invader. So it dials down your learned immune system, but then dials up your barrier immune system. And so some of the things that we see, melasma and skin hyperpigmentation is probably also in response to that. And so you can also see patients who form like keloids that can get much worse in pregnancy as well. Everything becomes hyper reactive and itching, everything can affect people differently in pregnancy. I don't know if if you react differently to different products now that you're pregnant.
Yeah.
Do you at all, Nicole? Do you react differently?
Well, I never had to use moisturizer until now.
Wait. Oh, yeah, because you use ZO. ZO doesn't believe in moisturizer, right?
Yeah. And I am now, my whole routine is just like 6 different moisturizers.
Wow.
So I'm definitely more of that. Like I became sensitive, dry.
Okay.
Yeah. Yeah. So I definitely did notice that. But the other thing with lasers, which I think, again, is more of a lack of research, but they're concerned about, I guess, those wavelengths reaching the fetus. I feel like there's plenty of barriers in between, but again, there's a lack of research. So I don't know your thoughts on that.
Yeah, I mean, so a lot of the studies, when it comes to these things, are things that probably. That one, I don't think they're going to study too well. I know that we don't like to do lithotripsy for kidney stones on patients who are pregnant because we can scramble a little brain when we're trying to get a stone, and that's probably a lot higher. I've seen patients who've had lithotripsy when they're pregnant and they ended up fine, but again, we want to steer things away a lot. Honestly, a lot of the studies on radiation and things in pregnancy are based on like proximity to nuclear bombs in Japan. Like there's not a lot of research on these things. It's very antiquated. And I don't think we're getting any closer.
Like, what podcast are we on?
Yeah. But it's like the interesting things in the medical, books when you look back and they're like, well, how do we know how much radiation is safe? Well, they said, how many miles did you live away from Hiroshima? And you say, what were, how'd you get radiation poisoning? And then that's, that has stayed for many years. And so we need, medical research and studies.
Right.
Yep.
But I think overall, right, Botox, fillers, and lasers, it's more of it's unpredictable outcomes too. We don't want to put you at risk or have an issue with healing or
of course
anything of that nature.
Yeah. And no one wants to say, I wish I didn't do this, one thing.
Right.
Because a lot of times we look back, things are either going to work out or they don't. And if something bad happens, we often as human beings, we want to look back and we want to say, this is the reason why. Even if it had nothing to do with it, but it makes us feel better. And so we want to, like I said earlier, eliminate as many variables. We don't want anything that could possibly hurt mom, possibly hurt baby. So the answer is usually no.
Yeah.
Right.
Don't do it.
It's going to be what you don't want to hear.
Yeah, exactly.
Microneedling. So microneedling is like little needles. They create little channels across the skin. It's like the vampire facial.
Sure.
There has been a few accounts on Instagram that have gone a little viral because they've said that they allow that procedure when pregnant. Again, I don't know your thoughts on that. Like mine would be, again, you're healing and you're worried about the pigment, and I don't know if it's worth causing injury to the skin. But if that would be considered safe, there's also a topical lidocaine component that might have different forms of lidocaine that I don't know if is worrisome either.
Sure. I mean, topical lidocaine we use, pretty often, and we use regular lidocaine in pregnancy. So I don't think that would be, a component at all. It probably depends when in pregnancy, and the patient's comorbidities. And again, the answer is probably no. But,
right.
In being safe, does it really have an adverse outcome and effect? Probably not. But, because we're causing micro trauma, could that stress, over time, increase if it's very early pregnancy? Theoretically, could you come to another conclusion that it can increase risk for miscarriage? I'm sure that there's someone out there that could argue that point. And so it's probably good. The answer for the meantime would probably be no.
I think honestly, it just makes sense to even, I mean, I know the whole retinol thing, obviously that's not pregnancy safe, but just to think of things that are safe during pregnancy, or like, thinking of things that your skin could react to. I mean, like retinols, vitamin C's, any, big actives, like obviously lasers, microneedling, you just don't know how your skin's going to react. So you better be safe than sorry and just wait till after, you're pregnant.
Right.
Yeah. You do have a lot of these changes that are transient because of pregnancy. And so if something is really bothering you, a lot of times we're telling patients, wait till after, we know you want it now, but wait till after after you're pregnant, because it might just go away on its own. You might not need any of this. Now, for a lot of these facials and things, people are doing those for wellness and to maintain their skin over time. So, they want to, keep doing these things. And I understand that.
What about red light therapy?
I have not heard anything as adverse, I actually,
I'm pretty sure it's pregnancy safe. I mean, I know, Nicole, you've been religiously doing your Omnilux while you can't get Botox.
Yes.
Yeah. That should be fine. It's just the light, right?
Right. Yeah. It's just like exposure to LED light. Yeah.
Colored light. Yeah. I mean, we go out in the sun.
We get so many people that ask that though. They're like, is it safe? Like, I don't know what to do. I don't want to spend money on this if it's not safe.
I posted that as part of my routine, and I got so many DMs like, wait, can you do that? I'm like, I mean, it's just light. So
it should be fine. I can't imagine, again, from the media legal standpoint, if you ask someone, they're probably going to tell you, stay away from it at all costs, because it could be.
Yeah, if you look on like Omnilux's website, I guarantee it tells you not to use it, but it's more of a liability thing. Yeah.
But like, and then again, like I have patients who are CrossFitters or MMA fighters, and the old adage was that, they were telling people to be on bed rest. Now I tell people, no, go, if you're deadlifting 200 pounds before you're pregnant, and you don't have something that's preventing you from keep doing it, and so we have to use some common sense too in treatment of people. We can't just say no to everything.
Yeah.
Another question I had was IV hydration, IV therapy. So, I know you, Nicole, you do it in your practice. We do it in ours. We have a Get Up and Go, which is like, it's got some like amino acids that help with metabolism. Sure. We have immunity. So, zinc, vitamin C, all of that. And then we have Myers cocktail, the typical, thing that you get in the hospital. So is IV therapy safe during pregnancy?
Oh, yeah. I mean, I would say definitely, because the first thing we do when you come into labor and delivery is pop an IV in you and start pumping you full of fluids. So I have so many women who come in who might be, have an upper respiratory or a kidney infection, or they've been on their feet working all day. They're dehydrated during the summer. You get patients, the joke is when it's, 95 degrees out, I said everyone's going to come in contracting later today because they're going to be dehydrated. And, and then they come in, they get IV fluids, and typically, if they're not in labor, they go home. So I can't see, as long as it's, recommended IV fluids and not something weird or crazy.
Well, and I would say too, like if you have, as a business owner, and I know, Nicole, you agree with this, if someone who was 8 months pregnant and they were they had a diarrheal illness and they were dehydrated and they wanted to come in and get a Myers cocktail, I would do it. Just make sure you check their blood pressure before and after, just to make sure they're good. Because if they have an elevated BP, probably not too smart.
Yeah, and I would say definitely call your doctor. Maybe go to the ER.
Call your doctor first.
If they're dehydrated, having diarrhea at 8 months pregnant, tell them to come on in.
Come on, sweetie. Go see your OBGYN.
Please go to the ER.
Don't see your aesthetic injector. Go see your OB.
Yeah.
Oh, it's too funny. I was told, because I was having a lot of nausea in the beginning, so I was told that electrolytes and keeping a good hydration can actually help with that. Is that true?
Definitely. And our first line treatment for nausea, vomiting, and pregnancy is going to be vitamin B6 and doxylamine, and again, small, stable meals, nothing crazy, kind of all of those things. And it's keeping a good hydration status, making sure that you're not overdoing it. All of those things are very very safe for you no matter what, whether you're pregnant, not pregnant or anything. Right. But again, it just good advice.
Yeah. Yeah. Going back, because you brought up the skincare before, John. I know they say to steer clear of like salicylic acid, but to a certain degree. Is that true, or should you again just try to steer clear of salicylic altogether?
Yeah, I mean, I don't have a lot of experience with salicylic acid, but again, it's probably going to be a no in pregnancy. Anything, if just I would stick to your normal scrubs and stuff without active ingredients. Is it a very is that topically absorbed where it's going to get to fetus at a high amount? Most likely not. But, again, I would stay away from any product that is controversial. Talk to your OBGYN, and they'll tell you no.
Yeah, exactly. You'll just get another no.
Yeah, those are you ask them and they'll certainly tell you no.
My next two things on the unsafe list were microcurrent and certain chemical peels. Microcurrent is gaining a lot of traction on like TikTok and things like that. I don't know if you've seen the new face. It's like a little device. You turn it on and it sends little waves to stimulate your muscles.
Okay.
But
it's a waste of money, in my opinion.
I've never heard of this. So
yeah, they say that it can help tighten the skin or the area around the eye, things like that. But again, there's lack of research, and with the microcurrent, they're concerned that current can travel throughout the body.
Okay. That one, we could try it. But I mean, like, what do we do when we ultrasound and everything? Yeah, we use some, use some sound and waves. And, when I have a baby that's not responding, on NST or something, I will tap them, or you can take a coffee cup and you can go, hey, what's going on? And like vibroacoustic stimulation.
Oh my God, I love that.
Yeah, you could literally do that if you don't have sometimes you take the button and you go, and you can get them to wake up. But I'll just give them a shove. I mean, it's still a baby in there. I'll just go, hey,
Nicole,
wake up.
Nicole, if your baby's not moving, I'm going to do it. I'm going to say, move, bitch.
The big cup.
Yeah, if you put the coffee cup on there, it'll amplify it. So
all of a sudden you'll get a swift kick in the diaphragm.
Yeah. Like, oh, there he is. No, they were doing that during my anatomy scan. They were like making him, because he wouldn't move, so they were just jumping on my stomach with that thing.
Yeah, you just they like give him a good couple shoves.
Yeah, chemical peels. Obviously, they're going to be high ingredient. Yeah,
I would probably avoid it, and that's more likely. It's more because you don't know how people's skin is going to react.
Right.
I've had patients who are using products they've used their entire life, and then they come in and during pregnancy and they break out in a terrible rash because, for something that they've used, or a cleaning product that all of a sudden they're sensitive to. And so I would probably stay away from doing anything that's high intensity.
Yeah. There's some chemical peels that I guess could be considered safe, like the aluminized peel. I don't know if you have that, John. Like those,
Skinmatica,
like the red
lunchtime
carpet
peels. Yeah.
It's just like that exfoliation, but not actually like a peel that's going to cause a reaction.
Sure.
But I feel like that would go more into just like your facials. You know, maintaining skin that way.
Definitely, and again, if it's fairly, non-abrasive, if it's something that is, very hyperallergenic, I mean, it's probably going to be safe. Right. But with the caveat that everybody reacts differently. Right. And, if, someone's pregnant, their skin might just react in a completely new and different way, and so that's just like a little caveat for someone who even might be doing a hypoallergenic peel. And then I'd always tell them, hey, if you're worried about something, call your OBGYN and they will tell you no.
Right. And you will hear that no again.
Yep.
So now to get into some safe stuff, your traditional, like you just said, the facials that aren't going to cause any kind of crazy irritation with any high ingredients, no retinol, obviously, but definitely your Diamond Glows, hydrofacials, things of that nature with the right ingredients, the LED therapy,
Glow 2 facial for those people that have Glow 2 facial is probably, safe to do. Yeah.
We talked about the aluminized peel. Dermaplaning. Dermaplaning is
the peach fuzz.
Yeah.
I mean, that should be fine. I can't think of a reason why that would affect. I mean, you're literally just, shaping up eyebrows and doing those things. Those things should actually be fine.
Right.
People
you're not causing anything crazy.
Yeah. People get their hair cut during pregnancy. They shave, we shave their abdomen before a C-section, or we clip it, like normal things like getting your nails done, dyeing your hair. These things, if you read a hair dye, thing, it says don't do any hair dye during pregnancy. I think, a common sense is that's probably not going to affect you in a way that's going to harm your pregnancy. But again, there's that standard no for everything. And so, it's use at your own discretion, talk to your OBGYN, but it doesn't make sense, right? It doesn't make sense why painting your nails is going to have an adverse reaction in your pregnancy,
Yeah. And like she said earlier, like you're not doing it every day. You're not getting your hair dyed every single day. It's something that's not happening frequently. Oh, with the acne, we just didn't touch on rosacea, because I know that the rosacea can be flared a lot of the times, sometimes with people. Again, it's probably difficult to treat.
Yeah. It's one of those things that you tell them to avoid triggers with rosacea and kind of, I know there's some people who have actually done corticosteroids occasionally if they're breaking out, but we don't like to do those too much in pregnancy. It's kind of one of those things that usually gets better. It's usually people with rosacea generally have rosacea and then it's exacerbated by pregnancy. And so it's avoiding those triggers a lot of times.
Yeah. And I did actually have a question come through about a clinician being pregnant on certain things that we offer. Specifically, if you have Pronox in your practice, if you should be in the treatment room when the patient is utilizing the Pronox if you're pregnant.
Okay, what's Pronox?
Pronox is laughing gas.
Yeah, nitrous oxide. Yes. Sorry.
Nitrous oxide is actually
nitrous oxide.
He's like,
sweetie, it's fine.
Okay, so nitrous oxide is actually, the rest of the world is used as labor analgesia in many, many different countries. So it's like one of the first line anesthesia analgesias for labor, actually. And so, as long as they're not making big financial decisions. No.
Is that too much of it? What'd you say?
No, where I trained in Michigan, we offered nitrous oxide for labor pain.
Oh, wow.
Yeah. And so you would get the whole, the thing, and they would sit there and they'd be like,
oh my God.
Yeah. They would have the mask and they'd take a big deep breath in while, while they're right before they're pushing or right before their contraction
came. Oh my God. So cool.
Yeah. It was super cool. And then they'd be like, all right, I want an epidural, please. They're like, I'm in a tremendous amount of pain, but I don't care as much.
But I don't
now
care.
I'm happy.
I was gonna say, if you missed that window, the epidural, that Pronox would be nice. The nitrous,
yeah. We would wheel it in. It would come like on its own standard cart with attached. Yeah, it was great. A lot of places offer it. Not around here.
Yeah.
But
yeah. I think it is starting to gain a little bit more popularity because I am hearing it more now being pregnant just from other people, but I don't know like exactly what hospitals offer it.
Yeah, you'd have to call ahead.
Yeah. Double check that one. I did have some off-topic questions. I'm not exactly sure what this person meant, but they put opinions on vaginal rejuvenation, and I'm not sure if they meant like surgical versus like, we have those. What's that seat now, John? Yeah, like things you can do.
Laser,
like
therapy.
Yes.
To tighten things up and
they just asked your opinion on that, like when to start that kind of stuff.
Is it Emsella? I can't remember.
Emsella. That's what I was thinking. Yes, yeah.
So it's just the nature of my practice. I don't do a lot of cosmetics because there are so many OBGYNs who just do cosmetics, who are excellent for doing labiaplasty and for doing, cosmetically driven procedures. And And so I'm a big proponent of, if you are uncomfortable during sex, if you're having a physical problem, or if there's something that's physically unappealing, or something that you want taken care of, go for it.
Mm-hmm.
Go get it taken care of. I just don't have enough volume in my practice where I'm, if I'm doing something, I want to be doing it every day, or doing it, all of the time. And so there are providers who have devoted their entire practice to that, and I'm all for it. And it's really just based on patient preference, right? When we're talking about cosmetic procedures, if we're talking about improving, appearance of vagina, appearance of vulva, or function during sex, then yeah, you should have all of those things, anything that you want. But I do refer out to providers for that generally, because it is a tough field. You want cosmetically for everything to be up to the patient's standards. You want them to have good outcomes. I do a lot of, besides obstetrics, I do a lot of minimally invasive gynecology. So I'm robotically trained. So I work on the Da Vinci. That's what I was doing this morning before I got on here. So I do a lot of hysterectomies and minimally invasive surgery. But I kind of, do OB. So I have a lot of pregnant patients, and I do my, minimally invasive gynecology. So I have a lot on my plate already. It'd be.
Do you offer hormone replacement therapy at your practice? Yeah.
Yeah.
100%. That was actually another question. Your thoughts on bioidentical HRT was the exact question.
Okay. So the problem, bioidentical HRT, the two problems with it are, number one, how do we determine what is bioidentical for a patient? And so what standards are those? And then the second is then how are we regulating that? Right. And so with bioidentical hormone therapy, you need good partners at your compounding therapy. You need to have systems to figure out what to do for people. And then it's like, how do we determine what's good for a patient? So the adage for hormone replacement is we use the lowest dose for the shortest period of time, and that's kind of the, cover your ass program for, not causing any harm. But, one of the things with, hormone replacement is that it's easy to standardize dosing and then move up in order to get your patient satisfaction. So I personally don't do bioidentical hormone therapy. However, I don't have really access to it. And so, for me, the cheapest thing and the most available to my patients is usually, using a standardized regime, so that this way I can move it up, I can move it down based on their reactions. And so, it's tough with anything bioidentical. It's going to be difficult to achieve those standardized success, and also things that are accessible for patients. So it's I usually go with the standardized hormone therapy.
Perfect. So I think that was everything. That's all my questions. We went through all the myth busters. We went through do's and don'ts, lots of don'ts.
Yeah. The answer is no. That should be the title of today's podcast.
Yes.
The answer is no.
And when in doubt, ask your OBGYN. Don't ask. I mean, you can ask your injector. We're well versed on everything, but ask your OB and just go based on that.
It's always going to be back to your OB. Exactly. Yeah. All right. Well, thank you so much for joining us today.
Guys,
this was incredible.
Fun.
Yes. This was amazing.
Cool. We'll have to have you back on.
Sweet.
Yes. Next pregnancy.
Perfect.
All right, guys. Well, thank you so much for tuning in to another episode of the Fill Me In podcast. I'm Injector John.
I'm aesthetic nurse Nicole.
And this is Punk Rock OBGYN. Dr. Simons, thank you so much for joining us today.
All right. Thanks for having me, guys. It was a pleasure.
Yes. Thank you.
All right. Bye, guys.
All I want.